Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. This podcast is on the 2025 guideline for the management of patients with acute coronary syndromes. It's hot off the press, published in JACC Circulation. The lead author is Dr. Sunil V. Rao, MD, FACC. Dual antiplatelet therapy DAPT updates in this document. Ticagrelor or prasugrel is now preferred over clopidogrel in patients undergoing PCI for acute coronary syndrome. Clopidogrel or ticagrelor may be considered for upstream therapy, that is greater than 24 hours after angiography in non-STE-ACS to reduce major adverse cardiovascular events. New DAPT duration strategies. Transition to ticagrelor monotherapy after 1 month of PCI in those who have tolerated DAPT. Early discontinuation of aspirin 1 to 4 weeks post PCI with continued P2Y12 inhibitor for patients on long-term anticoagulation, preferably clopidogrel. Lipid management. High-intensity statin therapy is recommended for all ACS patients with ezetimibe initiation as an option. Lower LDL cholesterol targets. It recommends additional lipid-lowering therapy, example PCSK9 inhibitors, inclisiran, bempedoic acid, if LDL cholesterol remains above 70 milligrams per deciliter. That's 1.8 millimoles per liter. Consider further intensification if LDL cholesterol is between 55 and 69 milligrams per deciliter, despite maximally tolerated statin. So really the goal is to get it less than 55. Invasive versus conservative strategy in non-STE-ACS. Routine invasive strategy is recommended in intermediate or high-risk non-ST elevation ACS patients. In low-risk non-ST elevation ACS, a routine or selective invasive approach with further risk stratification is recommended. Procedural recommendation for PCI. Radial access is preferred over femoral to reduce bleeding, vascular complications, and mortality. Intracoronary imaging, IVIS or OCT, is recommended for PCI guidance in complex lesions. Complete revascularization for multivessel disease is the way to go. It's recommended for STEMI and non-STE-ACS. Choice between CABG and PCI in multivessel disease should consider lesion complexity and comorbidities. For STEMI patients, non-culprit PCI can be performed in a single procedure or staged, but preference for a single procedure is indicated. Management of cardiogenic shock. Microaxial flow pumps, Impella, may be reasonable in select cardiogenic shock patients to reduce mortality, but come with increased risks of bleeding, limb ischemia, and kidney failure. Management of anemia in ACS. Red blood cell transfusion may be reasonable to maintain hemoglobin above 10 grams per deciliter in ACS patients with acute or chronic anemia who are not actively bleeding. Secondary prevention and follow-up. Lipid levels should be assessed 4 to 8 weeks after statin initiation or dose adjustment. Referral to cardiac rehab is strongly recommended with home-based programs for patients unable to attend in person. This is in a nutshell the recent 2025 update on acute coronary syndromes.